Welcome, sir, on board.
Thank you.
So now, without further ado, I will hand over the session to Dr. Chaudhary for further proceedings. Over to you, sir.
Thank you, Dr. Gajanan, and a very warm welcome to all my physician colleagues who are joining in. Very hearty welcome to each and every one of you. This topic is fairly common. In fact, I requested recently somebody to do a kind of a little survey with physicians as to what are the commonest problems they face in their day-to-day practice. And I was surprised that topping the list was actually dyspepsia, and followed by, of course, bowel disorders like irritable bowel syndrome. So that's the way it is, and we all seem to think that it's something common, so it's easy to manage. But let me tell you honestly, I find it very difficult to manage it, because you can be, if you don't understand the little nuances of which one to be treated how, you often are not getting a very rewarding response from the patients. Okay, so today we have two very eminent experts to talk us through this very seemingly easy but complicated topic, and both of them are stalwarts in their fields. So our first speaker will be Dr. Zubin Sharma. He is a senior specialist in gastroenterology at the Fortis Memorial Research Institute. He has got a particular interest in GI physiology. Most of you who know that, he's already at a young age started doing quite a bit of manometry and GI physiology studies, published a bit. And he is going to talk to us a little bit as to how to diagnose it, what is it all about, and so on and so forth. It has to be more than just an acronym of functional dyspepsia. And the next speaker is Dr. Rinkesh Bansal, a very senior person. He's the associate director in the Department of Gastroenterology and Hepatobiliary Sciences at Fortis Memorial Research Institute. He's got very vast experience, lot of publications. He's a very sought after speaker in many international conferences. So he'll be talking to us about how exactly to manage it at a more, shall we say, how to tweak which one to treat how, that kind of a thing, so that all of you are fairly educated about it. So with those introductory remarks, will just jump in. So may I first request Dr. Zubin Sharma to come and tell us what it's all about. Um, I'm sure, hopefully, he'll make it simple yet understandable, because sometimes, GI physiology can be a little technically challenging. But after that, once we understand, it will probably be easier for us to know how to manage. Over to you, Dr. Zubin Sharma.
Thank you so much, sir, for those kind words. I'll just share my slides. So, what I'll try to do is I'll try to show or highlight an approach to dyspepsia. So, whenever I speak on dyspepsia or I read about it, one of the first things that I remember was from my MBBS days. If you all remember the Bailey and Love that used to be there as a surgical textbook, there was a comment there which said that abdomen is a Pandora's box. Every day whenever we see dyspepsia is such a very common symptom, but it can entail so many of disorders and so many different presentations, is that today we really have to learn it in much more detail. So when we talk of dyspepsia, let's start with a simple case first. So this is a 55-year-old present lady who has come to our OPD with upper abdominal discomfort for last 4 months. There is some pain, some early satiety as soon as she eats. She complains of a non-significant 3 kg weight loss in 2 months. There is some diarrhea which is happening for last few years, intermittent diarrhea, although no alarm features like GI bleed or anemia. She is diabetic hypertensive for 5 years, and she is well managed with metformin and olmesartan. She has taken PPIs and prokinetics and everything for last couple of months, but there's no significant benefit. So this is a very routine kind of a case that I think we all as physicians would be seeing in our daily practice. And when we actually think of what can go wrong or what is the problem here, it's a huge list. It can be right from GERD, which is something like a functional dyspepsia or a gastroparesis, to something much more serious like a gastric malignancy. It's very hard to just go by symptomatology and try to differentiate which patient has what and how do you, to what extent do you test them. Now, symptoms can mislead because, as I say, that dyspepsia has a lot of overlap. This is from one of our textbooks, and you can see a huge list. So, what as doctors we have to do? We have to find these islands of organicity in a sea of functionality. That's what I commonly, tell my all of the fellows who want to learn GI motilities, that there are islands of organicity which will be in a sea of functionality. So that's where dyspepsia actually lies. So agenda is we'll try to define it, see the context, what is serious, what is not serious, what is happening in India, what are the common symptoms associated around dyspepsia, what are the pathophysiological processes, and how we can diagnose it. So the word dyspepsia itself is coming from the Greek word for maldigestion. So it was first described in 18th century in Scotland actually, but it attributes to a constellation of symptoms which is referable to the gastroduodenal tract. That means the proximal GI tract of a human. So it is a relapsing, remitting, and a chronic illness, particularly when we are talking about functional dyspepsia. But dyspepsia as a term can be a lot of things. It's common and it is expensive across the world. Why I say so? Because PPIs are probably the commonest drug that are used for functional dyspepsia, and it's a huge market. Even in 23, it was almost 10 billion, and over the counter, it's probably more than 15 billion now. So, what are the terminologies? When this patient came to you, that middle aged lady, it was an uninvestigated dyspepsia. You will examine the lady, you will do some investigations. In 30%, you'll probably end up finding some cause for it, which can be GI cause or non GI cause, whereas 70% would be what we are trying to discuss today as functional dyspepsia. When we talk of those 30% organic causes, you will find things like Helicobacter pylori, you will find peptic ulcer disease. Rarely you may find a GI malignancy. In pancreatobiliary, you can find both acute and chronic pancreatitis, sometimes presenting only as a mild discomfort. And diseases like CA pancreas, gallstone disease in an early area will not really have those classical features of jaundice or pain. They may just have some discomfort. So coming back to our case, we have done our physical examination. She is slightly obese, 28 BMI, borderline overweight. Rest is unremarkable. We did endoscopy and an ultrasound, which was normal. There was some atrophy in the second part of the duodenum, and we took a biopsy. H. pylori was negative. The labs were normal, and HbA1c was okay, not so bad at all. Now, what do we do more? So, do we now consider this as functional dyspepsia? Are we happy that Lokeshi falls into that 70% of that category? Maybe yes, but let's try to define that now. So, functional dyspepsia has had so many definitions over the years. The current iteration of that is in the Rome 4, which divides it into two broad categories. That is the epigastric pain syndrome as well as the postprandial distress syndrome. Now, this is a symptom-based classification. If you're a pain predominant patient, that is the epigastric pain syndrome. You have a postprandial bloating predominant patient, that is a PDS syndrome. So by pure definition, it has to be more than 3 days in a week or more than 1 day in a week. But for all practical purposes, I'll say do not be very hard and fast on these definitions coming in from Rome 4. They are mainly there for the research tool. But both of these patients can be there, and there are a subset of patients who will have overlap. Apart from the Rome 4, there are ACG guidelines, there are Asia Pacific guidelines, but they are, as I said, they are not very specific. Just remember all the symptoms coming in from the gastroduodenal area that can be in the umbrella term of functional dyspepsia. So EPS and PPDS is somewhere around one third, whereas a combination of both of them can happen in almost 35 to 40% of patients who present to you in your daily practice. In India, how do we see? So there have been two major studies. We have one by Dr. Uday Ghoshal sir. We have one by Dr. Shah. They are good in numbers. One is primarily in the rural setting. One is from the urban setting. And if you really see the details of it, you will see that both of them in India, a combination of epigastric pain and postprandial distress is seen. There is no real rural-urban divide here. Whereas, isolated cases of epigastric pain is 9 and 17% only. So majorly our patients will have postprandial distress syndrome, and they will, of course, as expected, overlap with irritable bowel syndrome also. Now, when we talk of overlap, you have to see that functional dyspepsia is a kind of disorders of gut-brain interaction. And when we say that, we have to understand that there would be overlap with things like IBS, functional constipation. Now, coming on to why it happens. So, as we said, it's a gut-brain axis disruption. So, you need to have multifactorial things into play. So all of those things like visceral hypersensitivity, impaired motility, mucosal permeability, altered microbiota, they are the ones which are the triggers in a patient who is genetically predisposed and has associated central factors, stress and anxiety. So it is a disease occurring at multiple levels like any other DGBI. And there are proven things like higher eosinophils, higher colonic inflammation, or higher duodenal inflammation, even in patients who have functional dyspepsia. Now, broadly, when we talk of the motility, which is also impaired in these set of patients, you can have impaired gastric accommodation and delayed gastric emptying. So stomach has two broad functions. It has to receive the food and accommodate it first. And secondly, once it has accommodated the food, it has to push it down. So if there is any impairment happening at both these levels, that means patient can't accommodate large amount of food, or there is a difficulty in pushing it forward. Both of them can happen and cause problems like functional dyspepsia. Now, duodenum itself also has a role. Whenever there is impaired accommodation or increased sensitivity, there is a slower gastric emptying. In a slower gastric emptying, you have higher acid exposure in the duodenum, and that actually leads to abnormal inflammation and responses to hormones. That itself also causes a lot of these symptoms. And why we talk about this today? Because this has been proven beyond doubt in at least 4 or 5 studies that duodenal eosinophils and mast cells play a strong role in patients who have functional dyspepsia. But we have also seen that they do not correlate well with the symptom severity. We have just seen that there is higher in patients who have pain predominant disease. Now, coming on to the next pathophysiology, that is the visceral hypersensitivity, that also has been proved that in patients who have functional dyspepsia, the visceral distension of stomach really causes, symptoms much more as compared to patients who do not have these. Now, how do you evaluate them? You go to the history. I think history is something which is very, very important here. You look at the symptoms, what is the predominant mechanism or predominant abnormality in your patient, whether it is epigastric pain, whether it is distress. If it is pain, look at the duodenum. If it is postprandial distress, look at the stomach. Look at systemic illnesses like diabetes, thyroid, hypertension, systemic sclerosis, autoimmune disorders. Look at what the drugs our patients are taking, because a lot of these symptoms are also triggered by drugs. What kind of diet they are on? Do they have any GI infections like giardia in the duodenum? What kind of stress or alarm features that they are presenting? So this is probably the single most important thing you can do is listen to your patient. What are the alarm features? Yes, where you will require an endoscopy. We all know that in India, age around 60 years, GI bleeding, anemia, dysphagia or dinophagia, vomiting, unintentional weight loss, some lumps, all of them will, lead you to a lower threshold to do endoscopy. In physical examination, if you find anything higher BMI, icterus, lymphadenopathy, please don't wait. Scope them or at least test them for something much more serious. A basic investigation set would be at least a hemogram, a LFT, a renal function test, an ultrasound, and things like thyroid and HbA1c. Now, who needs endoscopy? I think the commonest question asked is why should we scope everybody, or should we choose whom to scope? Now, as you can see, this table where we divide West India and the East, we have seen that in India we have much more higher H. pylori prevalence, although the gastric malignancy is relatively less in India as compared to the East. But most of the malignancies that we see are all, particularly stomach, are akin to the one in the East, that is the age is around less than 40 years. But the most important thing you need to see is that our survival is only 6%. That is why in India, I think it's important to scope these patients who have even a small alarm symptoms or no significant relief. And for us, the age cutoff should be around 40 years. And why do you see? You will see all these things. These are good high definition NBI images of early gastric cancer. It's also an opportunity for you to check for H. pylori, whether it is an H. pylori associated dyspepsia, and you can diagnose other conditions as well. So, but the problem is that as all of us, we will know 70% will have normal endoscopy. So the caveat usually people say is that, okay, the endoscopy is almost always normal. Yes, it is normal. But the other 30% where you will pick up something wrong is worth scoping all those patients. How do you manage them? I think Dr. Rinkesh will cover them in much more detail. I'll just briefly touch on the, a very broad guideline to it. If you have alarm features or age more than 40, do an endoscopy. Find out if they have H. pylori, and as well as you can go for an empirical treatment if there are no alarm features. Identify food triggers. So there are no standardized guidelines for functional dyspepsia as compared to IBS, but ask your patient to maintain a food diary, see their dietary patterns, look into their herbal supplements. A lot of them are on different supplements which should be stopped. You can test them in an advanced way. If you really have a bad patient who is not responding at all, you can do things like gastric emptying time, you can do an enteroduodenal manometry, and you can really see if they lie in that gastroparesis spectrum. Remember, patients of functional dyspepsia may have abnormal gastric emptying time. And if it's a spectrum that continues towards a severe gastroparesis where better treatment options like GPOM or pyloroplasty are available. So how do you approach them? Alarm, we already discussed, I'll quickly run through them. Alarm features, endoscopy, H. pylori higher than test, 10% like in India, treat for H. pylori. If you still have patients who have a PPI, that means postprandial distress, give them PPIs because as we talked, the duodenal eosinophils play a role and PPIs have a degranulation effect on the duodenum. If not, there are better agents which I think Dr. Rikesh sir will discuss. So coming back to our case, remember we took a biopsy in the second part of the duodenum and we were till now treating as functional dyspepsia and patient had not got better. We were trying to treat them with another set of PPIs. We had given them prokinetics. We had given them tryptomer. Patient was not improving. But the biopsy came back and it showed villi blunting with increased lymphocytes. Now TTG is normal, but this is the biopsy. Now going back to your history again, as I said, the history is the single most important factor. Identify a drug which has been being used in these set of patients and patient intermittent diarrhea. So olmesartan is something which is very, very important as a cause of such symptoms and cause enteropathy. Olmesartan induced enteropathy was a diagnosis in this patient. It was stopped and patient improved. So the whole point of showing this case was that in the history itself, you will find a lot of small clues which will help you to diagnose what is important, what is not. So to take home points are, you make a positive diagnosis, take a detailed history. There are significant overlaps. Gastric emptying time is available, but it may not correlate with symptoms. Endoscopy, take biopsies, look for eosinophils, lymphocytes. Remember the drugs that patients are on because a lot of these patients will be on multiple drugs. Assess for food triggers, think of elimination diet, treat for H. pylori if present, and first line therapy is PPI, particularly if you have a patient who has a postprandial distress or a pain. And then finally, there are better drugs which are also available. So functional is not an equal to a lack of abnormality. So what we today consider both of them, functional dyspepsia and gastroparesis, is as a severity continuum, and there are definitive clues in the endoscopy in the history where we can identify what to do better. Thank you so much.
Thank you, Dr. Zubin. That was Wonderful, actually short but very clear. There are a lot of questions, of course, I have. I'm a physician, so I find this a very difficult clinical problem. But I'll wait because I hope that Rinkesh will cover quite a few of them and then we'll take it further. So, how to manage them? So, Dr. Rinkesh, I've already introduced him to you, and he'll be taking us through how to manage this very difficult set of problems. Dr. Rinkesh, over to you.
Thank you, sir. Thanks, Lupin, for nice talk on Friday evening. Very important topic, and Jubin rightly set the stage and nicely covered the importance of the history and the subsequent line of investigations. So my job is to cover the medicational part, the fundus relaxant and prokinetics. What are their place in therapy? So we know that greeting from the Fortis, and we know that there are treatment options in functional dyspepsia. Mostly when the patient is positive, we give the H. pylori eradication therapy, triple or quadruple, depending on the patient's status. Then there are some medications we know H2 receptor antagonist, proton pump inhibitors, and now PCAB with the quite good experience in India also. We have some antacid syrup, raft syrup, and other things. And the most important, which is the point of discussion today, and there is a lot of controversy regarding the use of prokinetics. So I will cover in next 5 to 10 minutes about the role of prokinetics. So rest we know that it required. So when we start the treatment for functional dyspepsia, it is the PPI, or nowadays some other molecules like PCAPs and raft therapy. So we start with the PPI, and if the PPI are effective, we continue PPI for durations. But when there is a PPI refractory patients, we add some additional therapy. It may be prokinetic, it may be other things. So we need to identify the patients who will respond to the prokinetics. This is a quite important cartoon in which when the patients have reflex symptoms, so the most important thing, the patient presentation. As Jubin rightly said, if the patients had reflex symptom, we start prokinetic from the beginning. But when the patients have dyspeptic symptom, we initially gives PPI alone, and in the second week, we after second week we add prokinetics. Now there are lots of prokinetics available in the markets, and right from the cisapride and until recent one, there are some limitations. The main limitations are the side effects. Cisapride has some cardiac side effect. Then mojapride and etopride were not superior to placebo in early phases of clinical trial, though etopride have some data nowadays, and we use in some patients. The issue with the most common used levosulfide is the prolactin increase, galactorrhea, and change in libido. And that's why levosulfide and probability of Parkinsonism also. So that's why we should avoid at least for long therapy, and we should monitor these type of side effect. If we find that these are side effects are happening, then we should stop medication immediately. Most of the time they are reversible. Domperidone, which is used very commonly, also have safety issue, specifically QT prolongation, and sometimes a sudden cardiac death or cardiac arrhythmia also noted. So we should avoid this domperidone in specifically cardiac patients or kidney patients, just to avoid cardiac complications. Metoclopramide and domperidone are evidence are lacking in functional dyspepsia. There are some data about the other prokinetics like ketoprides, prucaloprides, but in functional dyspepsia, this is not so commonly studied. So the now is the role of ecosiamide. Uh, Again, this is also used as a prokinetics. It has the gastric accommodation enhancement as well as the gastric emptying, and it improves the fundus relaxations, and it increases the enteral motility. That's why it propels the food towards the duodenum. So we use ecosamiide 100 mg thrice daily before meal, and it is approved for treatment of meal-related functional dyspepsia, specifically the postprandial fullness, early satiety, and bloating. And most of the ecosamiide works well in specifically in the patient with diabetes. So there are some studies, some short-term study as well long-term study in which they are used quite commonly. So this is the 2-week gastric scintigraphy study in functional dyspepsia, and there is a significant improvement. Ecosamiide also used in another trials in different part of world, in Japan and in European countries, and it has some specific specific effects in postprandial distress syndrome patients. Now the long-term data, safety and efficacy of ecosamiide. So there are some studies for at least for 1 year data, and efficacy as well as the side effect profile were quite good, and there were no such significant side effect noted with these molecules. Functional dyspepsia symptom generally started to improve from early stage of treatment with the prokinetics. So we should use prokinetics in the early phases, and it the improvements effect was maintained even after the dose interruptions, and adverse reactions are quite less, specifically with the ecosamiide. To summarize, therapeutic options for patients with functional dyspepsia are limited. We should use prokinetics specifically for short durations. We should avoid the combination medicine, and we should avoid the long term prokinetics. There are some safe prokinetics like ecosamiide or etopride in comparison to others. Availability of these molecules in the market easily, and there are lots of studies nowadays in India and outside the India in which they are relatively safe, but they should be used judiciously and for a limited durations. And along with the PPI and prokinetic, the team efforts is always required. So we have the very eminent leader, Dr. Gordas, and my dear Dr. Jubin and others in our team. And thank you very much. I will be happy to answer any questions.